Hello, and welcome to the Health Go Live webinar series. Today's episode is brought to you by your friends at TytoCare. We would like to remind you that the Q&A feature is available, so feel free to send in your questions throughout the discussion. And with that, I will turn it over to our moderator, Hagai Hashez, who joins us from TytoCare.
Excellent. Thank you, Nicole, and thank you, Health. And thanks to everyone who joined us today. We're excited to get started. So I'd like to jump in and introduce our speakers today. Joining us today are Tamara Ward, SVP of Insurance Business Operations at Oscar Health, Alejandro Quiroga, Senior Vice President and Chief Medical Officer at Corewell Health West, and Dedi Gilad, CEO and co-founder of TytoCare. Thank you all for joining us. Let's get started with some introductions. Tam, maybe we can start with you. Tell us a bit about yourself, Oscar Health, your role there.
Absolutely. Thank you for having me. As the team shared, my name is Tamara Ward. I'm our Senior Vice President of Insurance Business Operations at Oscar Health, where I lead our national network contracting strategy and market readiness. I've been in the industry maybe a little over 17 years now, operating both on the payer and the provider side of the house, just leading transformational initiatives, payer provider strategy, and building high-performing teams. The organization that I work for is Oscar Health. It's the first health insurance company built around a full stack technology claims platform that is really focused on serving our members. We offer individual and family plans, small group, and Medicare Advantage across the country. And we also have a piece of our organization called Plus Oscar, where we sell the technology platform that we've built to other providers and payers to help them in enabling their own value-based care strategies. And thank you for having us today.
Great. Thank you, Tam. Alejandro, Ali, would you like to go next?
Well, thank you so much, and great to be here with great company. Nice to meet you, Tam, and thank you for having our organization here. So I am the Senior Vice President, Chief Medical Officer of Corewell Health West, formerly known as Spectrum Health. I've been in this organization for 12 years. Corewell is the merger of Bowman Health and Spectrum Health here in Michigan. We're the largest healthcare system in Michigan now. We are a $14 billion organization. We are an integrated healthcare system. We have Priority Health as our insurance arm, and Priority Health has 1.2 million members, which allow us to get into this value place with a leg up and design very creative models of care. So my role as the CMO is mostly with the medical group, population health infrastructure, Children's Hospital and Care Management here in the West Side.
Great, thank you, Ali. And finally, Dedi.
Hi, everyone. I'm Dedi Gilad, co-founder and CEO of TytoCare, and great to see you again, Ali, and nice to meet you, Tam. TytoCare works with leading health plans and provider groups across the world, mainly in the US, to roll out what we call today the Home Smart Clinic solutions to their members. Basically, these solutions give families an actual clinic at home that replicates the doctor physical exams for a variety of care modalities, including urgent care, primary care as the basis, but also longitudinal care like chronic management for asthma, COPD, and so forth, but also use cases like newborn development and so etc. Today, we serve roughly 900,000 patients that are coming from around 220 health organizations, mostly in the US, and about 20,000 clinicians on our platform. And great to be here.
Perfect. Thank you, Dedi. So let's jump to the first question. I'll start with you, Alejandro. We see a lot about value-based care in terms of different contracts, different shifts that organizations are making. Can you tell us what you're doing in terms of value-based care? What the transition means to you? What does it look like in your organization?
Yes, so thank you. Actually, my first SVP role here in the organization, I debuted as the SVP for Population Health, and this was close to 3 years ago. And that's really when our organization got a lot more serious about going into value-based care. And one of the first things that we did is all of the members attributed from Priority Health to our own primary care, which at the time were around 150,000 members. We're at 154 members from Priority Health alone attributed to our primary care. We went into a full risk arrangement. And this is all segments, right? Medicare, Medicaid, commercial, which, it was a good timing because this was just the beginning of COVID. So without building the infrastructure yet or not being fully baked, we went into full risk. And that's the beauty of being an integrated healthcare system. It allows us to just jump in the water. What we're doing with that, we started to design the infrastructure and a strategy around how to win in value. So then we can have this kind of full risk contract with other organizations, other payers. And it's interesting, like at the center of everything, obviously we went with analytics and basic infrastructure, but then we heavily started to redesign primary care and redesign care management. In the redesign of primary care, we live in these two worlds, and this is where a lot of healthcare systems struggles, right? Fee for service and value, and how do you get providers, clinicians, and the team that surrounds them to understand how to treat patients different, depends on the contract that you are. I'm a physician. I'll tell you, we hate that. We don't want to know that. We don't want to think in that way. The way we designed this is we wall off and we separated primary care and into two segments, into two areas: fee for service and value-based care primary care. And we wrap around the teams in primary care and value in a different way that we wrap around in fee for service, knowing that fee for service has been our historical standard. So just thinking and communicating very well that that's our historical standard. And now we're going to try different models of care here, and has been very successful. We open senior only clinics for co-chronic seniors. You have to have more than 3 chronic conditions, being older than 65, and being in one of our full risk contracts. We now have 3 of those clinics. We're opening some other clinics in the future. Total value-based care for providers in that clinic. Usually a primary care provider would have panels somewhere between 2,000 to 5,000 patients. In these clinics, the providers only see 500 patients in their panel. Open access, immediate access, transportation needs, social determinants of health. We also open some clinics that we call rising risk clinics for all segments where you are a chronic or co-chronic patients that might go into a different direction, and we'll wrap you around in the right way. And we also embedded teams of value-based providers inside fee-for-service clinics with the right wraparound services. And around all this, we have a commercial strategy and a Medicaid strategy with a clinic that only sees mostly Medicaid patients, where we embedded psychiatry, physical therapy, addiction medicine. So that is the primary care. And then what we did in care management, and I'll make this like a long story short, like we completely shift our care management for fee for service, and everybody gets care management in the same way, to centralize supporting this primary care redesign, and have a lot of programs there that we can talk more about if you guys are interested.
So pretty advanced with value-based care. Tam, what about Oscar Health?
Yeah, I think from a payer perspective, and here at Oscar, value-based care has really been at the core of our strategy from the very beginning. One would argue that our approach was first focused and centered around the member, and figuring out how do we help enable our members to better take care of their health through our technology, through our engagement strategies, and through what we would call our care management teams that we have dedicated to our member population. As you think about like truly being effective at value-based care, though, that's just one piece of the equation. Both the payer, the provider, and the member have to be aligned and engaged. And so over the years, we've really worked to set up the contracting infrastructure and the relationships that are needed to align incentives between the payer, the provider, and the member to better enable that value-based care. And so today, we have about 48% of our members tied to some type of value-based agreement. We're a national organization, and so what that agreement looks like depends on the market readiness. It depends on the provider's readiness. And so we try to tailor those agreements to really meet the provider where they are. I know, Ali, you mentioned, hey, you guys jumped right into risk. Some providers are ready for that. Others need to take a glide path approach to get there, starting with basic things related to PCP assignment and attribution, getting the membership right, getting the membership to the right primary care doctor, then slowly working your way to figure out, okay, how do we focus on quality? How do we ensure that we document and code appropriately? Then graduating into things like better management of utilization, and then other, I'll say, advanced technologies as what Title provides today to do things at home, more convenient, you name it. And so what we've tried to do at Oscar is take those agreements, take those aligned, provider partnerships, and enable them with the technology that we've created. I think what you find sometimes is that payers are going down one lane, providers are going down another, and they're not really working together to complement one another. And I think at Oscar, that's something that we pride ourselves on doing well, to not be an adversary or a distraction to the magic that the provider can create, but really be an enabler to that with our technology and with the insights that we're able to glean as a payer from all the different touch points that our members have within the healthcare ecosystem, and sharing those insights with our providers so that then they understand the best way in which they should engage with our membership.
Got it. Thank you, Tam. Dedi, what does Title Care, what does it look like in Title Care, value-based care?
So for us, really, this is an area that today we feel that we can really shine, and Title Care value-based program has to some degree really a unique match. Ali, it's really a pleasure to work with you and your organization on your value-based program. And of course, we're seeing similar direction and shift with other partners that are rolling this out. Today, value-based is growing rapidly, as you all know, and since most of our partners are already risk-based or entities, organizations like health plans and providers, we see a great opportunity and demand to assist those health systems. Like Tam said earlier, not all of them are ready to the same level to go not only on upside risk but also on downside risk. And Title becomes some kind of a bridge, technology bridge, to enable faster shift and more efficient shift to value-based contract.
Great. Thank you, Dedi. Next question is really maybe double clicking on virtual care. And maybe I'll direct this, start with you, Tam. What does virtual have to do with value-based care? How do you see those fit together?
Yeah, you'll hear me use the word complementary quite often. And that is, I think, how we see virtual care. A big chunk of our business sits in the ACA business, where oftentimes you see the membership transition in and out of those plans. So it's very, very transitional population. Sometimes they don't stay with one plan. Sometimes they don't stay with one provider. And so what we found is that with that part of the population, they tend to also not be anchored towards a PCP for a very long time. Not the entire population, but certain cohorts of that population. And as a way to help engage them in their own care, virtual was a natural option to help with that engagement, and a very convenient option that we believe COVID really helped bring to fruition more broadly across, I'll say, the globe. And so, we have what we consider to be Oscar Medical Group. We call it our OMG Medical Group, where we have virtual care providers that service our members that are, available for them 24/7. What we found is that with our own virtual program that, 98% of our members that engage with our virtual primary care doctors would recommend it to their friends, which means they're more likely to stay with the plan, which means they're more likely to listen and adhere to the recommendations of our virtual care providers. We're also seeing that 60% of that cohort is becoming more engaged in their chronic health needs. So we're seeing an ability to influence our diabetic patients. We're seeing an ability to influence our patients with hypertension and being able to enable them with the right, I'll call it tertiary services to help manage their chronic conditions. And so virtual has been a great place also for us to innovate. We've been able to deploy Spanish-speaking virtual primary care providers to connect with our Spanish-speaking membership cohort. And all of those learnings and all of the success within our virtual program really complements our providers that are also in value-based agreements. Because as I shared in the beginning, there are certain members that they're not going to a brick and mortar primary care office. I don't care how many times you call them, you can knock on their door, they're not coming, but they may engage virtually. That may be the most convenient mechanism for them to engage in the healthcare system. And for us, we found that to be extremely effective. We try to deploy virtual. I think, we were one of the first to deploy virtual care plans that were truly focused around this virtual experience. And we've seen a lot of success in that. But as we continue to think about our virtual strategy long-term, we're looking for ways in which it can complement our value-based care strategy. And we believe that it's a natural evolution in the convenience that members are looking for, especially for value-based care.
Great, thank you. And by the way, before I let Ali answer that, just a quick reminder that you're all welcome to ask questions during the session. I'll try to interject some of these questions to the panel here. There's a Q&A box you can click and just enter your question. So Ali, virtual, value-based, Corewell, how does that work?
Yeah, I mean, I love the question, and I see this question more of it's an in-between the right questions that we should be talking about, because in my mind, virtual has become a little bit more table stakes as before the pandemic. It was a differentiator. We were very early on to virtual in fee for service, and we stand up, a lot of urgent access through virtual. We created our own platform, and we have to come out of that once Epic built the platform, which is the EMR that we use. So I think I love how Tam says, frames virtual. For me, is an enabler. It's just the same way we have buildings, the same way you have virtual. The differentiator is how are you going to use it and the programs that you're going to build around virtual. And I think that's the area that we're experimenting, playing with a lot. Who wants to engage us virtually? Who doesn't want to engage us virtually? How do our doctors communicate virtually? I mean, it's interesting. During the pandemic, we stand at virtual ICU to help, or very large quaternary hospitals support the smaller, more regional hospitals. And to try to stand something like that before COVID would have been crazy. And there was a lot of engagement from the physician perspective, and we actually did a lot of great care. When it comes to value in virtual, I think, is meeting the people in the right place. When you're not in value, right? Having virtual strategies to approach our patients or our members, you in fee for service, you're thinking, well, if I approach you in this way, you're not gonna come to the hospital, you're not gonna come to the clinic, you're not gonna come to the ER, and healthcare systems will lose money. It is a complete flawed thinking, and virtual just allows you to think, how do I meet you there? How do we have RPMs? We're gonna have to be in patients' homes, and we have to engage people through their phones and their tablets and their computers and everything else. We have a lot of pilots going on in this perspective, and we partner with TidalCare from that perspective as well.
Thank you. Thank you, Ali. And Dedi, Title Care is all about virtual. How do you see virtual and value-based related?
Sure. So generally, as you said, although we are a pure virtual technology company, I would say out of the bat that the virtual alone is not enough. It's a key element. We do see a hybrid model as the most efficient one. That the people, again, at the end of the day, like Tam said, it's a combination of the plan, the providers and the consumers, the members, and they need to feel trust. So they need to have the access to all modalities. Virtual care, obviously, at its basis, improves access to care and also can bring much more efficiency. And that's what value-based care is all about, efficiency and better outcomes. And I do want to say, and I know part of our panel today is about engagement. Virtual alone is not enough. Having just, and we saw it in the pandemic and post-pandemic, just having the ability to connect virtually is not enough. You need to bring that trust, engagement, and the shift of the behavior to those modalities.
Right. So about engagement, obviously, yes, that's the session today. It's all about engagement and value-based care. When you think about value-based care, user patient engagement, member engagement isn't necessarily the first thing that comes to mind. There's so many other things, contract types, cohorts, conditions, infrastructures. Tam, you mentioned the infrastructures. So why are we talking about member patient engagement here? And maybe I'll direct this first to you, Dedi. What does engagement, you started talking about that, have to do with value-based care?
Sure, and we've learned during the years that it's not enough to create the access. It's not enough to have great technology and great organization that partners with you with the same vision. At the end of the day, and most of us are dealing and seeing many digital solutions, point solutions, that many of them are not succeeding. I believe, and we believe, and we've learned it, that engagement can really bring the effectiveness that we need. You can, bring the horse to the water, but you cannot make them drink. And without the engagement, those programs are not efficient. You will not see traffic, you will not see utilization, and you will not see your outcome. So for example, how do you make the members sign up for the program? How do you increase the utilization when some of the elements, at least in title, some of the use cases are episodic care, that people need to remind to use technology and not just go with their obvious way of calling a doctor. So those are the elements that we see. You have to hack this user behavior, behavioral change. We are working a lot with experts in that field with our partners to continue to improve it to specific codes. It's different with Medicaid, it's different with fully insured, and so forth. So I would say that today, what did not happen like 2 years ago, 3 years ago, we even created for the first time what we call Title Engagement Lab to really make that part of our secret sauce and ability.
Great, thank you, Dedi. And Ali, maybe to you. So engagement, value-based care, do you see a tighter connection there? Or what is the connection between engagement and value-based care?
I think value-based care is all about knowing the patients that you're caring for, that you have a capitated contract, that you're at risk. Historically, in healthcare, we compartmentalize the information in a way that does not enable engagement. The typical scenario is you come to a hospital and they're going to ask you the same questions 300 times until you're very upset and do not understand, and like you lose credibility as a healthcare system because it's like, how come you don't know the answer already? I've answered it enough times. In value-based care is not only do we know you, but can we predict you? Can we sub-segment you in a way that we're speaking not only your language? I love the Oscar Health like Spanish product. I mean, that's great, but not only we speak your language, but we understand your barriers. What will impede you to access the right care so it's more preventative, so you don't end up in an ICU, so you don't end up in one other hospital, so you don't end the ER. So engagement is, I think, everything. You can also make the argument for engagement and fee for service, and it's more of a differentiator and market share and so on. But in value-based care, it pays for itself every day of the week, is the right thing to do, and it will enable the results for sure.
Great, great. Tam, engagement.
I'll be a little probably more bold here and say, without the engagement, value-based care just doesn't work. You can have the best contract in the world. You can, have all these beautiful things in place, but if we cannot influence the member, by first having them engaged, we won't see the desired outcome. At Oscar, we have deployed through our Plus Oscar platform, a technology called Campaign Builder. And what Campaign Builder does is that when our members are on our app, searching, let's say they're sick, looking for an emergency room, we can prompt them to say, hey, it looks like you're looking for an emergency room. What's going on? You have a cough. You can go to an urgent care for $3,000 less. I'm being, facetious here, but you get my drift. And so with that ability to engage our members through our technology, we have been able to reduce the total cost of care. We've seen a 13% reduction in emergency room visits when we're able to engage our members through our app, real time, right? Wow. So when we talk about engagement, our members and our patients have to be engaged in a way that's convenient and easy for them to drive action. And so whether it's reminding them, to remember to fill their prescription, or it's reminding them or anchoring them towards going to see their primary care doctor, we've really built our organization, with the understanding that the experience of the member has to start with ensuring that that member is engaged. And when we have that member engaged, we're able to see the outcomes, positive outcomes, both in cost and quality from a highly engaged member. And I would argue, I think, Ali, with your value-based care work and your population health strategies that you're deploying on the provider side, your goal is to get that member in the office, to engage them and influence their next action, right? And so I would argue that if we don't have that in place, value-based care can only go so far.
Great, thank you, Tam. And you mentioned one example of giving them a notification in time that can really save them time and money with ER visits. Ali, any example that you can spell out of a user engagement element that had or has high impact on adoption of such programs?
So interesting. I mean, one of the hardest things to do as you switch from fee-for-service to value-based care is we have trained every single health personnel and the community very well for, if it's just this little much of complexity, go to the ER immediately. Does not matter what. And Tam mentioned some of the strategies for you to engage from that perspective. But it's interesting. I mean, like we had an early epiphany, which was, it should be very obvious. Every single one of our phone trees tells you, like, hello, go to the ER. Every single one of our forums, and if so, go to the ER. Call 911 or go to the ER. And part of our engagement strategies that have worked, we have actually put AI in really scrubbing our risk patients from the ER and getting them in the right side of care. That has worked really well. We have done a lot of readmission work with AI. We just actually published something in New England Journal Catalyst in January around how do we turn around every single, like all of readmissions for the system in 1 year. And that was through engagement as well. What I think is very simple concept and very hard execution in population health. It is just an ongoing exercise for finding a needle in a haystack. You just have to find the right patient. Every time you go about population health or any engagement and you just want to go broad peanut butter spread, you want to reach out to everybody, you're doing the wrong engagement. What has worked for us is that very targeted, finding the right population, subsegment very fast, very data driven, and then approach them with the right language and the right format.
Thank you. And Didi, any example of a specific engagement method that you've used?
Yeah, we see a lot of areas, and we obviously very much data driven and continue to improve and see how can we again make engagement more efficient. What we find as one example is the welcome visits have a massive impact on the patients, on the families. These are more or less pseudo visits that are giving the user first hands of experience with the technology. In title, you are shifting the behavior to really do self-exam, the physical exam on your family members, on yourself. So it gives them really some kind of an aha moment, opportunity to really experience the value of the technology, to really see how it can be used in day-to-day. So when the time comes and they have the need, it becomes more easy to remember and more fluent for them to shift to that behavior. And we title statistically wise, once people experience the technology, their ability to continue and use that later on becomes much higher. 70% of our members who did one visit with title continue and use it later, and this is one example.
Great, thank you. I want to interject with one question from the audience here, and maybe I think it's for both Tam and Alejandro. Virtual care builds compliance. Why? How does virtual care build compliance? Does it?
Compliance in terms of the medical perspective, like does it allow patients to be more compliant, or compliance from the legal perspective? And I'm assuming it's compliance from the medical perspective, but whoever has the question, feel free to clarify. I saw the question, I was thinking about it.
Yeah.
I think the jury is still out to say that virtual improves compliance. Like a lot of things, intuitively, I will say yes, and I'm actually willing to stick my hand in the fire to say yes, but I'll go back to a previous comment that I made. Virtual is a little bit of table stakes. Just the same, it's saying like having built-ins with doctors improves compliance. Depends. Are the doctors nice? Do they have access? Are there like, do they have the right support teams or not? In the same way, virtual can improve compliance tremendously by adding the same things that you can add in the physical world. But I'm not aware of very strong literature showing that it does as a peanut butter spread or as a general statement. Using the right hands in the right way, I yes.
Yeah, I would agree. Yeah, I would agree with Ali in that for certain patient cohorts where they are not able to engage or be influenced in a typical, let's say, brick and mortar primary care office, virtual can be powerful because there would not have been another opportunity for us to interact or engage with that member. It's also another touch point to remind the member of gaps of care that need to be closed, medication adherence that needs to be addressed. That's an opportunity for your virtual primary care provider to give them alternative options when they believe they have an emergency, call them, go to urgent care, as you name it. And I think, again, all of those things are complementary to the work that happens in the primary care office and helping to drive, lower cost, higher quality.
Great, and I'll interject maybe with one more question. And thank you, Ken, for your question. Hopefully this answered the question. I see a question from Boris here, Borislava. Great webinar, quick question. Can you differentiate, I'll direct this to you, Didi. Can you differentiate between the different types of virtual care? And also if you can speak about async versus sync, and do you see one more effective than the other? But first of all, what are the different types of virtual care that you see today?
Sure. You know, in the industry, you can see all varieties, all the way from just a plain phone call, like used to be when we were kids or the parents. It is a lot of the transactions today or the visits are still phone-based. Obviously, video-based, text-based solution. I would say that most of those modalities are great to some level of clinical need. Obviously, for mental health and things of that sort, it's a great way. But when you are diving more into primary care or more chronic care, monitoring patients or specialty care, you need much more than those. And then tools like Taito adds the missing element of the physical touch and the trust to use those. In terms of synchronic and asynchronic, we see, you know, at the end of the day, efficiency-wise, asynchronous is the preferred mode. Consumers can use it when they need to, and they don't need to be prepared. They don't need to schedule anything, and they just send it, and clinician can have the best, most efficient use of their time. But in some cases, certainly when you need when you have the need to educate people, to get the trust to the certain level, synchronous interactions are also critical. So we allow both remote exam by yourself or by a clinician, and we support both.
Thank you, Didi. And actually, first of all, thanks everyone for your questions. The questions are flowing in. So these are great questions. And maybe we'll have time maybe for another question before we move on to my next question. And maybe I'll direct this to you, Ali. And by the way, these are questions for providers, for payers. So this is a great mix. So Ali, one question here is, how are you empowering physicians to make value-based decisions for the patients? So choosing the right medication for the first time to avoid trial and errors or anything that's related to value. How are you empowering your physicians to make value-based decisions?
Yeah, that's great. I mean, I think many things come to mind. I mean, one, we're compensation for physician is a very touchy subject that is like, you know, the starting of many conversations when you're a physician leader. One of it is like we're incentivizing them to do what's right. So oddly enough, in fee-for-service, physicians might choose to do and have certain behaviors that overall as a community, if you look the data and the literature behind that, we will agree that probably not the right behaviors. Also, when you're at risk, right? I mean, there's certain things that might not be in the formulary for a plan, but you can make the decision as an organization to allow that. There might be a device that is not allowed or in the formulary, or you need a prior authorization, and you can decide, we're gonna absolutely eat the cost of this and do this procedure because it's right. Do this medication first, as you say, because it's right. What we have built around that is our own governance process for that. It's very early on, it's not at the maturity point that we want, but we have this payvider committee where when people have these ideas that before they were just squashed at first, now they're analyzed and this led by physicians. The plan is there helping us with some of the infrastructure that the plan has. You know, they have a different know-how there, but it enabled us to make those decisions, and that's great. And we want to eliminate prior authorizations for all value stuff. You know, we hate prior authorizations. We understand why they're have been important in our industry, but physicians, we hate it. We have eliminated prior authorizations for certain things, and it is a very welcome measure for our providers.
Thank you. One quick question for Tam from an anonymous attendee, this time with no name. So are cost savings for your organization or patients or both with value-based care, maybe specifically with virtual value-based care? Where are the cost savings?
Yeah, I would say any cost savings that, you know, we're able to generate through value-based care is really a cost savings for everyone involved, right? If we're able to deliver care or enable care at a lower cost higher quality that allows us to reduce the premiums, which ultimately allows, the member to have a more cost-effective health plan. And so that trickles down, in the economics of a plan and how premiums are set. Those savings also, when we have aligned incentives, are shared with our providers. So I would say for it would be cost savings for everyone.
Thank you. So let's go back to engagement and user engagement, member engagement, patient engagement, and value-based care. And all of you mentioned a few examples. Tam, you mentioned the in-time notification, and Didi, you mentioned the welcome visit. How do you measure success or impact of your engagement strategies? Maybe I'll start with you, Ali.
I think Tam said it very well, right? Value-based care equals engagement. If you're not doing the engagement, you're not doing value-based care. You're really your levers are limited. So I think the best way to measure this is the same way that you measure value-based care. I mean, like, you can measure total cost of care, site of care, quality of delivery of care. Those are like very simple measures, but very hard to accomplish. You can measure the engagement, right? I mean, some of those results will have like, they're very targeted. So number of conversions, every time that you reach to someone, and did you accomplish what you want? And there's different ways to do that, but that we also measure that.
Okay. And Tam, how do you measure the engagement and whether an engagement tactic is effective?
Yeah, I think it's really how Oscar has built its full stack technology platform, and that what we found is that when we have our members engaged, 68% of them trust us to advise them how and where to get care. Once that trust is established, then we can influence the outcomes that we'd love to see. For example, for that 60% of our 68% of our population that's trusting Oscar to help direct them to go see their PCP or to go to an urgent care instead of a more costly emergency room visit, we've ran what we can consider to be campaigns where we've been able to increase PCP visits, getting our members in to see their PCP by 15% because of that engagement. And so we start with measuring those outcomes at the very beginning to ensure that the activities that we're deploying are actually driving the value that we want to see. But one thing that I'd say that's super important to getting the engagement right are two things. One is connecting with the member at the very beginning. And I'll even say this for the provider side, connecting with the patient as soon as you know that they're your patient. You're much more likely to influence their behavior and get them engaged at the very beginning. And so for us as a payer, it starts with our welcome kits. Our welcome kits really welcome the member to our plan. It helps them understand how to engage with us as a payer, how to engage with their network. It encourages and almost prompts them to download our app, because we know that when we have them download our app, we're able to get them engaged even more and help to influence their behavior even more. And then second to that, so engaging the member or the provider at the very beginning is critically important. But the second piece I think about engagement, I know, Ali, you talked about, value-based care is consistently looking for a needle in the haystack. Engagement is consistently iterating and learning from the things in which you're deploying. So we may deploy an email campaign one week. If that's not effective, we're going back to the drawing board and saying, that didn't work for this population. Like, that didn't resonate with them. What could we do differently to help influence their behavior, meet them where they are, speak their language, to enable the right, I'd say, activities that we want them to take following that level of engagement that we're trying to drive.
Interesting. So you mentioned both the onboarding and the first phase, and then continuously optimizing, learning, optimizing, implementing. Thank you, Tam. Didi, how do you measure the impact of your engagement tactics, your user engagement tactics in Title Care?
Sure. So as I said, we actually created this title engagement lab that we continue and learn and improve and create those blueprints. So when we start a new program with a specific type of cohort of members, we know what to anticipate. We know what is the marching orders and where do we need to go to. But when we analyze to begin with the data and to compare tactics, we do a lot of A/B testing between members from the same cohort, the same demographic data, the same type of families or patients, and really check and compare different behavioral science methods. So as an example, and I agree with Ali, at the end of the day, it's very simple to start with the basic. The basic is what I would say traffic or utilization into this service. And we are very proud to say that Taito, compared to the other modalities that I mentioned earlier, we see on average 5 to 6 times higher utilization, which is basically people actually shifting physical interaction to a digital one. It's a very simple thing to compare, and we can compare it to people, to members in the same population without any digital capability, or with a standard digital, or with Taito. We also measure a lot of the results beyond the actual total cost of care reduction, and this is mostly done by our partners using claims data. We have few researches that just going out as we speak right now from 2 payers and 1 pay provider that are showing 10%, 10.3% total cost of care for any family with Taito and so forth. But we also measure more basic, how many of the visits ended up with closing the loop and not needing any face-to-face interaction later. So those are some examples of how do we measure the engagement.
Thank you. Thank you. And maybe I'll interject a question I see here that I think is relevant. I just saw this. Regarding pharmacies, and that's interesting. Maybe I'll direct this to Ali. Virtual pharmacies, engagements. Where do pharmacies fit in?
Oh, I love the question and I hate my answer. I mean, pharmacy is something that we're working very hard this year, and we're redesigning a lot of our care around what we're doing with pharmacy. Part of the integration is one of our focus areas for integration, and there's a lot of great things that are going to come. Historically, we really have struggled with a lot of things. I mean, I think I should obtain a virtual PhD on pharmacy reimbursement for the work that I've put in the past year, just to try to understand how do we get reimbursed, how does this work? But I think there's a real play there. We have pharmacists embedded in some of our value clinics. That works. They do some virtual care, not at the scale that I would like it to be, but just think about it, right? I mean, virtual care, what allows you is to magnify and improve access to certain type of resources that then you can centralize. So it is a lever that I'm after, and you can also standardize care better in our value clinics. For instance, pharmacists do their own appointments sometimes. Like a lot of the work that some of our doctors are doing is really managing very complex medications. And to be honest, pharmacists are better equipped to do that and get better results. Some of our pilots, we have actually allowed pharmacists to manage diabetic medications for our patients, and we have had great improvement of diabetes control. So just virtualize that and it's going to get a lot better. I love the question, hate my answer.
Thank you, Ali. And Tam, there's a specific question for you here from JP, who's asking, how do you scale virtual if you have national members have provided license in 50 states? And which of your services are virtual? So how do you scale that?
Yeah, it's not easy. It really depends on the regulatory environment in each individual state, unfortunately. Sometimes it does require that you have a licensed provider in that state. Sometimes it requires that you have a brick and mortar facility to support that virtual care in that state. It just depends on the state regulations.
Mhm.
However, what we found is that states and where we have a decent sized population, it is worth that investment. I think as organizations consider how to expand their virtual programs nationally, they have to consider the regulatory environment and, you know, the return on making that investment there. For Oscar, though, our focus has been on virtual primary care and virtual urgent care, because we believe that with our population, that's where we have the best influence to date.
And can you maybe say a few words about the difference between virtual primary care and virtual urgent care?
Yeah, virtual primary care, you have the same virtual provider throughout the year. Like that is your primary care physician. That is who you call, you know, when you're, you know, ill or when you have to get an annual wellness visit, or, you know, if you see something, you know, that you need to talk to your physician about. Virtual urgent care, which most folks are more accustomed to, is where, you know, it's more immediate access. It's for urgent / emergent type situations where you can't get directly into your primary care. And so there could be members who have a brick and mortar primary care physician, but they leverage our virtual urgent care. Make sense?
Yes, absolutely. Thank you. Okay, so I will say we have one last question. Maybe we'll have time for another question from the audience. We will try to answer all the questions in email. So thanks everyone. And there's a lot of questions, great questions from the audience. Thank you very much. I'd like to ask a question to the entire panel as far as where is it going in your organization? So taking value-based care in 2023, 2024, what can we expect to see from you? Maybe I'll start with Ali. What can we expect from you? What is exciting about your next step with value-based, maybe specifically value-based and virtual?
Yeah, thank you. I mean, first of all, we stood up the same virtual urgent care and virtual primary care. And I think those are like very key levers. And I think part of like the natural evolution is how do you connect that to the physical world? And how is that a continuum and not a separate type of program, right? For instance, we have a program with this virtual urgent care, then you can translate that into a home urgent care visit or risk patients. How do you connect the asynchronous with the synchronous and the physical world? But where we're going this year is really all around how do we embed and engage specialists virtually and physically in our value-based care programs. Primary care is the right place to start. Care management was the right place to start. As you hit some maturity, then the levers are pharmacy and specialty care. So we're very excited about redesigning a lot of the care that we're doing in orthopedics. That is, we spent all last year planning for that. We have a GoLIVE next month, and some of that has a lot of virtual elements. We're virtualizing and want to virtualize even further some consultations or endocrinology and diabetes management. And then cardiovascular will be later in the year with some programs that we're trying to deploy. Very exciting for us.
Thank you, Ali. And before I let you, Tam, answer that, just to tell the audience, we have 3 or 4 minutes. At the end, we will be able to put a QR code that everyone can scan and sign up to get a TidalCare device and give it a try. So don't leave yet. But before that, Tam, what do you see coming for 23, 24 when it comes to VBC and virtual?
Yeah, we're looking, I think, at Oscar at the opportunities to continue to leverage our technology to grow both of these programs. I think we see a unique opportunity for us to enable providers, clients of our +O, technology to really enable clinically and analytically to help drive the results that we want to see with value-based care. As we think about our health plan, we want to start to unpack more of, I think, the results that we all talked about at the very beginning, that aligned incentives between the payer, the provider, and the member that we'd want to see. And so, you know, as a payer, as a insurance plan and a technology platform, we want to build the technology, continue to iterate on the technology to enable the value-based care. And then we want to advance the value-based care relationships in markets in which we have membership and plans. And so we see that as a continuous test and iterate, but it's here to stay. And I think a core component of our organizational strategy.
Perfect. Thank you. Dedi, what do you see in 2023? 24.
So we as a technology company specializing on the virtual side, we see basically three vectors. Two of them are aligned, I believe, with the direction of the market. And some of the maturity of virtual care is in two trajectories. One is, the doctor in the cloud that used to be for the virtual urgent care, as Tam said, is going now deeper into the community. So, and this is also connects to what Ali said, how to connect the physical world with the virtual world. So we enable today, and we're trying to improve the way to engage clinicians in the communities, specialty doctors in virtual, and even your own PCP. So you're not limited. You can get an umbrella of services from the doctor in the cloud all the way to your own PCP and professional. The second one.
Sorry, Dedi, to cut you off. Before we leave, I want to put up the slide with a QR code. Everyone who wants to get a title, just to give it a try, you can scan the QR code. Sorry, Dedi, you can speak on this slide.
The second part is the care modalities, not only the episodic care, but also longitudinal care like chronic condition management and so forth, preventive. And the last one for us is really around the deeper technology, AI, offloading the burden care from clinicians and giving more control and power to the consumers, of the family, to manage their own health. So we are releasing very soon the wheeze detection and crackle detection for lung diseases that will help us also improve the chronic care management and so forth. So those are the three areas.
Perfect. Thank you, everyone. Huge thanks to our speakers today. It's been a pleasure hearing your thoughts. Thank you to everyone in the audience for joining us today and for the excellent questions. And of course, a big thank you to Health for hosting us today. Have a great day, everyone.
Thank you for having us.
Thank you for having us.
Thank you to everyone that joined us today. Please visit our website at hlth.com to catch up on all Health Go Live webinars. And join us in Nashville, March 26th through 29th for VIVE 2023.